SBAR. What exactly does SBAR stand for? Why do we use SBAR? And most importantly, when do we use it? So SBAR stands for Situation, Background, Assessment and Recommendation. It is a well-recognised form of communication between professionals, used both in the NHS and outside, i.e. in the private healthcare settings, be it nationally or international. The SBAR is a very effective form of communication. It is essentially a method that ensures the information we are relaying A is concise and B, the way in which we relay this information is consistent. On most occasions, the information that we relay in the SBAR is only that which is clinically relevant. There are various occasions when we will use SBAR. For example, when in GP setting we will refer the patient over to the hospital setting for a second opinion or further investigations. We may refer the patient in, for example, the emergency setting to other members of the multidisciplinary team. For example, in the context of a neck or femur fracture, to the orthopedics team, or otherwise in the situation of an acute abdomen to the surgical team, and sometimes to the mental health team in the settings of mental health patients or crises, as well as to the front door team, the physiotherapists and the occupational health members in situations where we require an assessment of a patient's physical ability. When we are admitting patients, we will do an SBAR then as well, and this will be over to the medical team. The information that I relay in the SBAR in the latter circumstance is a little bit more detailed, including the social history, etc. The SBAR that we will come across in the early stages of our clinical training, whatever the clinical training course that may be it physician associate, medicine, nursing, and amongst many others. When we start performing OSCE stations, we will be asked to deliver at the end or conclude with an SBAR. I'm going to give a few examples now of what an SBAR might look like in the early stages of the training, followed then by an SBAR on the back of a clinical examination, and then finally an SBAR that I might use in the context of the ED setting, say with a neck or femur fracture. So here goes for the first example. Say that you have just performed the observations on a patient, a 25-year-old female, Nikki, and you are going to now relay that information to the examiner at the end of your OSCE station. So this was observations performed on 25-year-old Nikki, a female, as asked of me by the senior clinician. There is no post-medical history or comorbidities. The observations were all within physiological parameters and normal physiological limits. The patient had a new score of 0. I would recommend performing further observations on a 12-hourly basis unless there is evidence of deterioration or a clinical need otherwise. And that was your situation, your background, your assessment and your recommendation in order. Now, example number 2, where you have, say, for example, performed a neurological examination of the upper extremities in 45-year-old Mohammed. Situation. So I just performed an upper limb neurological examination in 45-year-old Mohammed, a male, as asked of me by the senior clinician. Background. There is no post-medical history or comorbidities in Mohammed's case. Assessment. Gross neurological examination of the upper limbs was unremarkable. Deep tendon reflexes measured 2 out of 4 bilaterally, all present and equal without the need for reinforcement. Muscle power testing of the upper extremities measured 5 out of 5 on the MRC scale for muscle power testing. Sensory testing of the spinothalamic and the dorsal column tracts was unremarkable with no neurological deficit. Recommendations. In the absence of any findings here, I'm quite satisfied. However, I may consider performing a full neurological examination of the lower extremities as well as a cranial nerve examination, and if there is a need, I may consider conducting some nerve conduction tests, plus or minus a CT scan of the head, and even if necessary, an MRI scan of the head. Now, final SBAR, the example I'm going to give is a patient who has had a neck or femur fracture in the emergency room, and I'm going to hand the care of this patient over to the medical team, the orthopedics team rather. So here it goes. So we have 89-year-old Betsy who has had a fall to the left-hand side. This was definitively a mechanical fall as Betsy turned around and lost her footing. She landed on her left-hand side. There was no evidence of a long lie, and Betsy was brought in by ambulance. That was your situation. In terms of background, Betsy suffers from COPD as well as known to have atrial fibrillation. She is on some medications to reflect the same and therefore is on anticoagulation. Assessment of the right hip demonstrates external rotation and shortening of that side with pain on passive motions, internal and external rotation, as well as axial loading. Betsy is unable to perform SLRT on the right hand side. The left hand side is unremarkable. I've assessed the shaft of the femur and the knee, and there is no obvious tenderness in the said areas. We have confirmed radiological imaging to reflect a neck or femur fracture intratrochanteric with significant displacement of the distal portion superiorly. There is no involvement of the rami or the acetabulum or clinical indication to suggest the same. Neurovascular status of the right lower extremity is unremarkable. In terms of recommendation, I have recommended some analgesia for the patient, and in the absence of any medicinal allergies, I'm happy to administer some IV paracetamol as well as morphine. I am in the process of contemplating a fascia iliaca compartment block to induce some regional anesthesia. I would appreciate a review by the orthopedics team, by yourselves, so as to further inform the management, be that surgical or conservative. And there's your SBAR in 3 various examples, from a very basic observations, followed by the typical kind of SBAR you will do on the back of a clinical examination, and then what you might see in actual practice in the hospital setting. Thank you for watching.